And and that is taking away my time from patients. And ironically, when patients complain, they call their insurance company and they say, no, I can't get this drug because the pharmacist says it's not getting paid for. They're getting told, well, your doctor didn't get it approved. And of course, I've just spent a half hour or an hour speaking through various levels, even up to the medical director, and he says, and some of these medical directors says, well, we have to go by the algorithm. I don't have the authority to change it. Well, then why do we need a medical director? Artificial intelligence or a computer could do the same thing, or that 18-year-old minimum wage person who you talk to when they're looking at the screen, they can do that without the medical director. Well, of course, the whole thing is aimed at making sure that we don't go through this process, that we don't spend the time, because it's costing us money. When I started practicing 40 years ago, we used to buy generic medications by the thousands, these big, huge bottles. We used to, diuretics, common diabetic medicines, etc. And we'd sell them for $2 or $3 to patients, $2 or $3 for a month's worth. Patients loved it. At that time, nobody had insurance that covered medications, and that's why that worked. Well, pretty soon, when all these things happen, as you know now, that we're not allowed to do that unless I register myself as a pharmacist, just like I can't have a lab, I can't own my own x-ray, etc., the start clause and whatnot. But it occurs to me, how come the insurance company now can own the pharmacy and decide what can be sold and what can't be sold, and decide on this price. So anyhow, to make a long story short, I have a couple of proposals. They're doing this to hit us in the pocketbook, and so that we don't prescribe these drugs, the ones that they don't like on the formulary. As of January 1st, what's happened now is we're seeing preferred generic drugs. It used to be brand names, you could see brand names, you don't have to argue with it. But now they have preferred generics, and other generics in the same class are not covered and whatnot. And the amount of time that it takes to get to the medical director, he might call you back a week later, you're wasted all that time. Their algorithms are often outdated. For instance, in diabetes, they say, well, have you used the sulfonylurea first before we go on to this other? And nobody uses sulfonylureas except the last resort anymore. That's not the standard of practice, so that all their algorithms need to be updated. My proposal is this. First of all, I don't like the idea of the federal government doing too much in medicine anyhow. I'm in that school of thought. But if they do regulate insurance companies and whatever government, they should say, the first rule should be that a medical director has to be available to me within a half hour or some reasonable period of time, day or night, 24 hours, 7 days a week, just like I'm available to my patients. Second rule should be that if somebody already has a medication approved by another insurance company, then they should change their insurance company. That should be grandfathered in, as well as if they change their preferences, the patient that previously was approved cannot be arbitrarily changed and then have to start all over with a different medication. I think that would be helpful because it would cost them money to hire the medical directors to spend all that time. The other thing that would be helpful is to make sure that if I speak to that medical director and he finally makes a denial, and then I have to put on that chart that that drug was denied, I need to put his name down there, and not just the name of the insurance company, his name personally, and he should be just as liable as I am for that decision in terms of any kind of malpractice and so forth. So that's basically my proposal. Thank you very much.